Let's now begin our last module, topic death and dying. It seems fitting to end the course with this particular chapter, so let's proceed. This particular figure examines death anxiety by both age and gender. So if you had to give a two-sentence summary of this particular figure for a test, how would you summarize it? Take a moment and formulate your answer to this question. If we examine gender, we'll find that both in early adulthood and late adulthood, women are slightly, and again, it's just a slight difference, women are slightly more anxious. If we compare anxiety from early adulthood to late adulthood, we'll find that there's a moderate less anxiety displayed in late adulthood as compared to early adulthood for both sexes. Let's consider places of planned death. So not accidental, but planned. Home, I think, obviously is the preferable option. Unfortunately, only 1 in 4 adults in this country will die at home. For those that are dying at home, hospice is almost always involved. Hospital setting, depersonalized, and it's inconsistent. You didn't live your life presumably in a hospital unless you're a medical person, and yet you're ending in a hospital. So not necessarily a fitting way to end, but most typical. Nursing home. The nursing home's focus is not on terminal care. The quality of the care will improve dramatically when hospice is involved. This might be a slightly more fitting place to die than a hospital because many people have spent years or even decades in nursing homes. So it might be a more fitting end than a hospital death. Well, in terms of where we die, it's a little disappointing. Home, 20% of us. A hospital, 60% of us. A nursing home, 20% of us. So home where we spent our lives, or nursing home where we might have spent the last years or even decades of our lives, are far less likely to be the place that we leave this earth. Unfortunately, the most likely place by far is the hospital. Let's turn to the topic of hospice and start with its giants. Its founder worldwide was Dame Cicely Saunders. In the US, its leader was Florence Wald, and Dr. Elizabeth Kubler-Ross was not only instrumental in hospice in Europe and in the United States, but is probably most well known for her 5-stage of death and dying process that we'll talk about later on this chapter. The goal of hospice is not to shorten life or to extend life, but to increase the quality of life that is left to the person. Normally, I would ask students to share their interactions with hospice if they were comfortable, and typically in most classes I'll have a student or two. It might be a grandparent often with the age of my students. Sometimes the person remembers the care done for their loved ones. Other times it might be particularly striking how they themselves were helped with the process. But hospice is an option that virtually everybody in our culture has and makes dying an easier and more dignified process for both the terminal patient as well as for their loved ones. So we've noted that the purpose of hospice is not to hasten death or extend life, but rather to increase the quality of the life that's left to the person. A major focus, in fact, the major focus of hospice is palliative care. This might be a new term for you, and that's perfectly fine. Palliative care refers to the reduction of symptoms and stresses associated with highly serious illness. Palliative care is not just specific to hospice, but it's given to anybody with serious illness. In the case of hospice, the person often has many challenges. There may be challenges related to pain control, challenges related to shortness of breath. There could be challenges related to nausea and vomiting, or the opposite, constipation. And focus of this care is not only for the individual trying to enhance their physical state of being, but also their psychological state of being as well. And that would extend to the patient's family and friends, offering support and guidance in this very difficult time. When you're spending time with a person that is terminal, remember that hearing functions longer than the other senses, so words absolutely matter. Please also remember that in the end stages of life, when you're visiting the person, the hospital, if it's a hospital setting, is often alienating, and holding the hand of the person, no matter male or female, no matter what age, is often very, very comforting. And don't be afraid to have conversations that should be had. Express thanks, express what needs to be expressed, because you'll lose that opportunity forever. So don't leave words unsaid. Don't leave sentiments unsaid. Since hearing is thought to be the longest lasting sense in the dying person, it's a good idea to keep talking to that person as they pass. Express that you're there, express that you love them, express that it's okay for them to go. Uh, it'll be comforting to that person and probably for comforting for you as well. Let's consider some legal terminology which we need to know. First term, Advanced Medical Directive, AMD. This is a written statement of desired medical treatment, which would be used when you were not able to make your decisions, maybe unconscious during a surgery, maybe stricken by COVID-19, maybe with dementia, and so on. So this would be your desires of what would be done and would not be done for you. Let's consider types. Living will. The difference is that the living will does not appoint a specific person. If you're hospitalized, often there's a temporary living will that you must fill out, but it does not name a person. It just indicates what you do want and what you don't want done. Now, contrast that with durable power of attorney. I hope I said that right. Durable power of attorney for health care, or sometimes it's called medical care. This is the same thing as a healthcare proxy. This appoints a specific person to make the decision. Appoint well because they have the decision and they can actually supersede what you have in writing. So again, pick carefully. Let's consider some more important terminology which we need to learn. First one, medical aid in dying, abbreviated MAID, and euthanasia. The similarity is that both bring about a peaceful death. As we learned from the previous slide, euthanasia is not legal in any state. MAID is legal in some. Now to reiterate, in euthanasia, the person would act, for example, the physician would act to end the person's life. In MAID, the person must take their own life. For example, maybe the doctor would set up an IV for euthanasia and administer it. In MAID, the IV would be set up, but the person would have to maybe inject the syringe full of whatever into the main fluid delivery bag. Dr. Kevorkian made a machine. He pressed the button, and if it was in MAID, the person would press the button. So euthanasia is illegal in all states. MAID is illegal in 44, or in other words, it's legal in 6 states, plus Washington, D.C. MAID has been available for almost 30 years in Oregon and has worked very well. Maine also has a version of it. Death with dignity legislation is now under review in 26 states, including New York. Most Americans, 2/3, support it and would like to have the option. Interestingly though, when people are making decisions for a loved one, most patients choose neither. Instead, they choose ending of life-sustaining treatment, such as, for example, diabetes medication, heart medication, nutrition, and so on. So what are the major reasons why we seek MAID? And again, What do those 4 letters stand for? See, medical assistance in dying. Okay, excellent. Decide what you think on this list would be the top 2 ones and the 2 bottom ones, and then we'll see how well you predict on the next slide. So again, the 2 top and the 2 bottom, you don't have to rank them in terms of the top highest 2 and the bottom highest 2, just top and bottom is fine. Were you surprised? I was. I was expecting that concern over pain control would be at the very top. But as we can see, the very top is losing control over one's life and not being able to enjoy life anymore. The bottom 2, the inadequate pain control and becoming a burden. So interesting. But again, these are the top reasons, the top 5 reasons why people do seek medical assistance in dying. Many cultures have a 24-hour rule, which refers to after death, the person must be buried within that 24-hour period. It tends to be places with very hot climates, and understandably, concerns over disease are probably the major motivator of this particular cultural mandate. For this chapter, I researched various death-related traditions worldwide. These cultural traditions aid acceptance of death. I thought we would start with the Mexican Dia de los Muertos. Please go to the link, and I think you'll find it very interesting. Look at funerary and grieving rituals in various cultures who might seem exotic to us. The first topic I chose was sky burials, typically associated either with Tibet, which is the picture on the left, or specifically amongst the Lakota and Sioux tribes in Native America. In the Tibetan sky burial, it's conceived as a gift of generosity, giving back to the environment, giving back. Anthropologists have also thought that the ground is extremely difficult to dig in and would typically prohibit a typical burial. On the right, you see a picture of a Lakota sky burial. The remains are prepared differently, obviously, than the Tibetans. Amongst Tibetans, 70% prefer a sky burial. In the U.S., sky burial is not a legal process. Suspension burials are an unusual funerary tradition found primarily in China. Let's consider the condition either pronounced sati or suti. It's an Indian tradition. Originally, it was voluntary. The wife would, as an act of devotion, throw herself on the funeral pyre of her husband. Later on, this became, in some instances mandatory. Various conquerors of India have been appalled by it. A Mughal emperor in the 16th century, which would be 1500s, banned it, and so did the British imperials as well. The most recent case was 2004, where the wife tried to do it and the sons intervened. As you can see, it was thought to, when it became mandatory, it was thought to maybe discourage Indian wives from killing their husbands. In many cultures throughout the world, including the Norse Vikings, pets were killed to accompany their owner, slaves, servants. Again, this is not limited to the Vikings, but in many cultures. A somewhat uncommon practice is called defleshing, when the flesh is removed from the bones. In the Andes, the people are boiled first to facilitate the process. This was done occasionally by European cultures in the Middle Ages. For example, King Louis IX, to facilitate moving his body back to Europe more easily, his body was defleshed. The next few slides also show variations of this defleshing. As you can see, defleshing is practiced in the Philippines. In the picture on the right, yes, the person wearing white and red is a deceased person that is in the process of being preserved for defleshing. A very uncommon process involves the re-exhumation of the body and it depends. The body might be interacted with and dressed, such as the people on the left and right. In Indonesia, the bones are turned. So not a common practice, but still not limited to just one society. In a modern process in South Korea, the body is turned into glass-like beads. This slide does not consider funerary processes, but rather a grieving process. In Papua New Guinea, fingers would be amputated as part of the grieving ritual. This practice is outlawed, though certainly still practiced to a certain extent. And perhaps the most unusual of all, we witnessed it in Turkey when traveling last year. When a person dies, the government will pay for the funeral and provide the family a dinner on that day, because the family is obviously in the grieving process, and this is to assist the family. A really nice government benefit. So I hope you enjoyed the previous slide. That was our introduction to grieving. Now let's consider grieving by death type. I've seen multiple losses are extremely hard to bear and can be associated with its term bereavement overload. Also probably obvious that sudden death, which allows no preparation, is much harder. Suicides are particularly hard to bear because no matter what the circumstance, invariably the friends and family will wonder if they did anything to cause it or if they could have done anything to prevent it. So suicides are particularly hard on individuals. Sudden deaths are particularly difficult for children, and in terms of thinking of responsibility for suicide, children virtually always think that they've participated in the causing of a loss of a parent. Prolonged dying process related to disease does allow the person to mentally and intellectually prepare. I don't know that anybody could ever fully prepare, but it obviously makes the process much easier. If you look at relationship type, hardest would be the loss of a child, a partner, or a parent. And again, the multiple or sudden loss, again, is an aggravating factor. Significant loss for children and teens are very, very hard for them to bear and to understand and to cope with. Again, if any of this brings up issues for you, please do reach out to our college counselor, Mrs. King. She is very, very excellent, and I cannot say enough about her. And she has gone fully virtual, so you could easily talk to her virtually, and just want to put that out there for you. So I would assume that if I asked many of our students to explain the difference between grief and bereavement, they might have difficulty. Let's clarify. Grief is the internal experience of loss, which you go through internally, emotionally, intellectually. Bereavement is the outer expression of this. And bereavement varies quite a bit from culture to culture. I included just a couple slides for us to take a look at and to consider. So in the Victorian times, women would garb themselves in black, no color at all. Full mourning would last a year and a day, so I think, ladies, aren't we lucky that we do not have to do full mourning anymore? Whereas in Western culture, we associate black with the mourning process. In Asia, the color is white. If you notice the spelling of color in this slide, I decided to go British. In various cultures, there is a long tradition of having a professional mourner. The wealthier the person, the more professional mourners would be hired. Let's consider thanatology, the scientific study of death and dying. When I taught at Jefferson College in Watertown, we did offer thanatology, though we tend to like to have it be taught by a practicing psychologist because it often stirred up grief issues in the students. It's an excellent area of course for people that are involved in either psychological services or medical issues. So it would be great for counselors, it would be great for people in the medical field, amongst others. Probably the most famous thanatologist would be Dr. Elizabeth Kubler-Ross. Dr. Ross was a country doctor, Swiss, and when her patients were dying, at a certain point she could offer them often little medically, but was still there for them and supported them psychologically. In her country, most people were dying in their beds, either looking at their view of the mountains or a view of the city. And she was horrified and saddened when she visited the US and saw that most people are dying in hospitals. And we saw the current statistics on that recently as well. She visited this country time and time again, helping to propagate the idea of hospice. And I consider her one of the three main players in hospice, both internationally and within our country. She's probably most well known for her stages of grief, which we've already explored in this particular chapter.